Hello, everyone, and welcome to this webinar from the Chorus Urban Health Systems team. And we're really delighted to be presenting at the International Conference on Urban Health. And we have a great list of presenters from across the countries where Chorus is conducting its research. And we're really focusing here on gender and social norms and how they influence health-seeking behaviour and health systems in cities in West Africa and South Asia. So we are all part of a research consortium called Chorus, which stands for Community-Led, Responsive and Effective Urban Health Systems. And we are made up of ARC Foundation in Bangladesh, BRAC University also in Bangladesh, Herd International in Nepal, the University of Ghana, the University of Leeds, University of Nigeria, and I'm from the University of York. So we have presentations from Nigeria. We have Chinyere Mbatu. From Ghana, we have Dr. Lauren Wallace, and Herd International in Nepal, we have Abriti Arial, and from ARC Foundation, we have Dr. Sushama Kanan. So what we're going to be looking at today is looking at the analysis that we've done of various qualitative data that has been coming from our Chorus needs assessment work that we've been doing in these 4 settings. And we really want to be able to look at these sort of cross-country similarities and differences in how gender and other social stratifiers influences health and health-seeking behavior. So just a bit more about Chorus. As a research consortium, we're looking at these 4 main areas. So in real recognition of the whole range of providers within cities, so public, private, informal, and ways that you can bring them together across the health system. We are very conscious of the wider determinants of health in urban areas and how there's a great need for multi-sectoral collaboration. So this is another area of focus. We are looking at non-communicable disease and how you bring those into health systems that have traditionally focused on communicable diseases. And underlying all of those is how you work with urban poor communities, how you reach them and engage them within the research process. And across everything we do in Chorus, we look at gender and intersectionality, both in terms of how we work as a consortium, but also in terms of the research that we're doing and the interventions that we develop. So these are our kind of overall aim is around developing high quality research to really influence and inform health systems interventions. So the next phase of our work will actually be delivering health systems interventions and evaluating those to inform policy and practice within the 4 countries where we're working. So in Bangladesh at the moment, we have 1 large project and 1 smaller project, and the large project is in Dhaka, and in future we're looking to work in Khulna, in Ghana, in Greater Accra, in two areas, Medina and Ashaman. In Nepal, this initial project is in Pokhara, and Nigeria, Onitsha and Enugu. So what we have done within Chorus is find a framework that helps us to think about gender and intersections with different social strata. So we found this framework from Morgan et al. Really helpful in doing that. So it's a very sort of simple framework that asks key questions about power and how power relations might be different amongst different people in communities and in households and in health systems. So looking at all of those different levels. And when we're talking about intersectionality, we're looking at social strata in different contexts and how that interacts with gender. So males, females, people of other gender identities, and how those gendered characteristics interact with wealth, poverty, occupation, ability, disability, and any other characteristic that is key in the particular context. So it could be race, ethnicity, caste, all of these issues, how they intersect. So all of our presenters are going to be using this framework that really looks at the different levels of access to resources. So who has what, and who has access to those resources, who's does what in terms of the division of labor, and that could be within the household, it could also be within the health system. How are values defined? So this is about the wider social norms, the ideologies and beliefs in societies, and then really the rules and decision-making processes as well. And then within that, how can change actually happen? I think this is something that's really key in Chorus. We have the luxury of quite a long-term project, so we have time to try to disrupt some of these wider systems and to try and change some of those gender relationships and the wider sort of structural environmental conditions, the legal and policy issues, planning and programs that actually can reinforce some of those discriminatory practices and gender divisions. So I don't want to talk any longer. I'm going to pass to my first presenter on this session, which is Chinyere from the University of Nigeria. Chinyere, if I stop sharing, hopefully you can share your slides. And while Chinyere is just getting her slides up, I'd like to ask all the attendees and anybody listening, if you have questions, if you think of questions, really active listening as you're hearing all the presentations, just write them in the chat. And then once we've gone through the 4 presentations, we can come back to the questions and discuss those with the whole panel. So please do put your questions in the chat as we are going through the presentation. Chinyere, over to you.
Thank you very much, Helen. And hello, everyone. I'll be presenting findings from our situation analysis on gender differences in health, seeking behavior, and use of informal, private, and public providers in 2 Nigerian cities. And I'm going to focus on the findings from the focus group discussions, which is the data that we have been able to collect and analyze, although we are still collecting data, quantitative data. So we are working in 8 slums in Enugu and Onitsha cities. And we've conducted gender segregated focus group discussions with men and women, randomly selected men and women in the 8 slums. So we have done a total of 8 focus group discussions. And we had participants ranging from 7 to 10 per group, and totaling, coincidentally, 34 men and 34 women participating in the FGDs. So we've just analyzed, based on the demographic characteristics and socio-economic characteristics of the respondents, of the participants in the FGD, who has access to resources in terms of income, what they do, their profession or employment, as well as the level of education, disaggregating for the women and men, and also access to health services. And from the table, 10 of the women and 15 of the men, we can see, did not actually indicate what their profession or employment was. However, there's a fair distribution of profession or employment across both genders. It's very glaring, though, that the number of women who are unemployed is actually higher, maybe significantly higher than the number of men in the FGDs who were unemployed. And then looking at level of education, overall, the level of education actually appeared to show that more women had, at least some education, and even higher education, secondary education compared to the men. However, we had more women who did not have any education compared to the men. Then with respect to access to health services, we looked across the different types of informal and formal providers in the urban slums. The women often stated that they had access to traditional birth attendants, or that they were using traditional birth attendants. The men never stated this in their FGDs. For the patent medicine vendors, it was often stated by both categories of respondents. And for utilization of formal providers, the men actually stated sometimes that they would use health centers and private hospitals. In the women's FGDs, they rarely stated or mentioned the health centers and primary and private hospitals. Then with respect to who does what, traditionally, men are perceived as the breadwinners, but this perception is actually changing as the roles of men and women in household provisioning are also changing. In single parents' homes, and this is actually specific to mother-only homes, the woman actually takes on the role of the breadwinner. However, irrespective of who is the breadwinner in the homes, the women were actually the primary caregivers, particularly when it comes to health care. Then how values are defined regarding health-seeking behavior. So we looked at some structure, some values that are more tangible, and then less tangible values like beliefs. So ease of access to provider, waiting time, opening hours, and affordability. So the characteristics of the provider actually define where people went to, whether men or women, and popularity or reputation in the case of men was also a key value, a key attributes that defined the values of the respondents. Then there's also referral from older women to the younger women, and then the perception that a provider helps people. So altruism was also a value. In addition, for women, also how the provider treats people, whether the provider treats people well and the provider is considerate. Severity of illness is also something that cut across both categories of respondents. So whether the illness, how bad the illness is, or whether it's persisting and no longer amenable to informal service providers, will determine whether they progress to formal service providers. Then their beliefs, the belief system, beliefs about illness causation. So their values are defined by their beliefs about whether an illness is caused by spiritual problems or superstitions and all of that. And also the belief that God is the ultimate healer, So, and there's this quote that at the end, it is only God that heals. So it will determine and define their behaviors. Then for the men, a lot of them often stated, or rather, they actually often stated that herbal remedies were good, so that their belief in the efficacy of herbs, that some illnesses are only amenable to herbal or traditional treatments, and that people respond differently to treatment modalities. So some people felt that, they respond well to traditional herbs, and others respond better to orthodox medicines. So, and these are some quotes that we got from, just to highlight what they said. So the first one touches on an issue of affordability. irrespective of the fact that they know that the chemist shops, so the chemist shops are the informal providers, that they know that they are
sorry
drugs.
to interrupt you. You have 2 minutes left.
Oh, okay. So irrespective of this, that they will still go to them because they are affordable. The second quote also speaks to affordability. The third one speaks to the issue of reputation and for men too. So we see that men also spoke about affordability and all that. Then for who decides, women decide the first point of care. And as previously shown, this is influenced by all of those factors. But men actually play a role in deciding where next. So when the first point of care is not working, then men come in. Health workers also decide the type of care to provide and whom to refer clients to. Now, with respect to what constitutes power relations among the different social strata, so there's this quote from a client about a provider, a woman, a female provider who did not treat his son well, and that he almost killed that woman because of that infected injection. So, and we didn't get this kind of response when people talked about poor quality of care provided by patent medicine vendors, for example, who were not women. Then for formal and informal providers, there's collaboration and recognition that occurs when the formal provider when, for example, the bone setter is a male formal provider, it's his establishment, and then he employs professional nurses, females, to work with him. Then so I just have this slide on how gender intersects with other social stratifiers in health seeking. So just highlighting some quotes from 3 different women with 3 different social locations, for example. So they are all female. The first one has secondary education, the second one tertiary education, and the last one tertiary education. However, the first 2 are unemployed, the last 2 is employed, and how their health-seeking behavior actually varied depending on all of these factors. So we just see it changing from someone who the least, or rather the most vulnerable in quotes, who will just go to a chemist, then the next person who knows that she can go to a hospital depending on how her illness progresses. And then the last person who never goes to the chemist or the patent medicine vendor, who is the most privileged of the 3. Then, so just also highlighting that access to health services is influenced by the type of care that is sought, and also bringing out the quotes to support it. So depending on their perception and the type of care they are seeking, they will either go to formal or informal health provider. So thank you very much.
Thanks very much, Chinyere. I think really interesting to look at that analysis and really see health-seeking behaviour in terms of those differences across sort of education and occupation as well as gender. Thank you very much for sharing that. Just to let any of the participants know, please do put your questions in the Q&A. And I'm very pleased to welcome Lauren J. Wallace from Ghana to present the findings from their qualitative work in Accra. Over to you, Lauren.
Thanks, Helen. Okay, so I'll be speaking about the impact of gender and other social identities on access to and provision of primary health care within the context of Ghana's community-based primary health services program, or CHIPS program, for vulnerable groups in urban poor neighborhoods. So CHIPS is a key strategy in terms of Ghana's approach to primary health care, and it operates through zones. The whole country is zoned by population, and community health officers who are specially trained nurses are placed in these zones to work with communities to provide a basic package of primary healthcare services. And the services are listed here, but they include child health, reproductive health, and other clinical services like first aid, nutrition, immunization, as well as NCD care. And the program is delivered through community mobilization, health outreach, home visiting, with support from community health volunteers, as well as community health management committees. So I'm not going to say much about this slide because Helen has already explained that this presentation is presenting findings from the needs assessment, which is part of a larger study, which in this case, our study is participatory action research, and the end result will be co-producing interventions and evaluating them together with health workers and local government and communities. And so right now we are at the diagnosing phase of participatory action research, and we'll soon move to the action planning and other phases. The study contexts Helen mentioned, they are in a Greater Accra, Ghana, Ashaiman and Medina, and we have 2 communities in each of these municipalities that have been selected. In terms of the methods, this presentation draws on 2 primary methods from the needs assessment, and these are community entries, including breakout group discussions, as well as transect walks. For the community entries, we conducted an event in each community with members and leaders of relevant associations, tribal and religious leaders, local government and health workers. And we had breakout session discussions in each of these community entries. So we split the big community group into about 6 or 7 groups and had small group discussions on who is vulnerable, what is the meaning of a vulnerable group in the community, what kinds of formal and informal health services are available, and how do people access these services, what kinds of facilitators and barriers do residents face to using services or accessing them, and also from health workers' perspectives, the challenges and facilitators they face. And then we did transect walks to follow up on the themes from the breakout sessions. These were 2 transect walks per community, and the researchers walked together with community representatives who were identified. And we had conversations along the way on our walk with residents and health workers along the same line of questioning as I just discussed. We also drew a map. So we had planned our route based on the objectives, and then at the end drew a map of where we had stopped, key points in the community, where different health facilities are located, and pharmacies, etc. Who has what? So in terms of the health workers' perspective, access to time, logistics, and human resources influences the services that can be provided in the CHIPS program in these settings. We found that access to services for both men and women of all ages was curtailed because of resource challenges faced by nurses, including human resources, logistics, and time. Usually in each zone, there is an outreach point, and a community health nurse, 1 or more community health nurses, depending on population, should be stationed there to provide services. And in addition to this, home visiting should also be conducted on a regular basis. However, there are limited numbers of nurses in these contexts. So this creates the need for nurses to rotate between outreach points in different zones. And this means that home visiting is not done to the extent it's supposed to be done. And also, we found that the CHIPS program, as it's implemented in these settings, mostly caters to maternal health and sexual and reproductive health activities like child welfare, weighing, immunization, family planning. So this engages predominantly women and their children, and it leaves men and older persons out. In terms of residents, access to time, income also influences their use of and access to healthcare, with a lot of similarities to what Chineri was saying. With minor illnesses treated in pharmacies, more major illnesses can be treated in facilities, and decision-making around which facility to go to or whether to go to the pharmacy or not, dependent on the expense, with the understanding that even if residents are enrolled on the National Health Insurance Scheme, the scheme does not work as intended. So when residents need to go to a health facility, they end up paying out of pocket anyways. So as a result, they prefer to go to the pharmacy if they can. And going to a facility also wastes a lot of time. And in this context, residents don't have a lot of time because they're busy working. Facilities can also be a long distance away. There are some communities that have no public health facilities in their communities, so they have to travel out. And then in terms of their preference for formal and informal, again, lack of money plays a role, but culture also plays a role. So herbal medicine use was common across all settings, but it's more common, we found, in Muslim communities. In terms of who does what, I conceptualize this in terms of the division of labor, in terms of the work that residents are doing. So you see that the kind of work that they do exposes them to certain health issues. The urban poor across all 4 communities are engaged in activities like trading, artisan works, and manufacturing, both men and women, and with certain gendered differences. So men would be the ones more engaged in manufacturing and things like plumbing and carpentry. Women are more likely to be engaged in sex work, and that exposes them to unwanted pregnancy and sexually transmitted infections. And there's a picture on the left here, and it's a picture of morning after pills, a very common one that we found when we went to pharmacies. When we asked pharmacists and others working there what the most common drugs used were, they mentioned malaria and other drugs, but also this particular drug, which is, and the one beside it, which is an morning after pill. And they said it's very, very common, especially among sex workers. Men are also engaged in scrap dealing, cement works, etc. And this exposes them to workplace injuries. And they express that they wish that they had more services from CHIPS available to them to do with workplace injuries and first aid. In terms of social norms, ideologies, beliefs, and perceptions, these communities, they perceive certain people to be outsiders and some to be insiders. And it affects how CHIPS and health workers are received in sub-communities. Health workers may not be the same religion or ethnicity, and as a result, they have trouble accessing communities. In a rural setting where ethnicity is more homogenous, this is easier for health workers, and the CHOs in a rural setting often actually stay within the communities where they work. But in an urban context, that is not possible, and there's a lot more diversity. And then we found that some minority ethnic groups. Thank you. We found that some minority ethnic groups are marginalized. The value of community engagements in these settings is also different, and it impacts the extent to which community health workers can be engaged, and health workers end up having to try to find incentives and money to compensate community health volunteers. It's not being provided from higher levels, even though that is part of the strategy. And community health volunteers could actually be a way to reach certain populations and certain ethnic groups, but it's difficult to engage them within these communities. Okay, so finally, the structural and environmental issues. I've mentioned resources a lot and the ways that they constrain some of the activities that the CHIPS program provides, which could be useful to make it more relevant across different social strata. Under Ghana's Local Government Act, financing and other functions for primary healthcare are expected to be devolved to local governments. But the CHIPS program in primary healthcare remains largely under-resourced and under-prioritized by local governments. And that contributes to some of the challenges on the ground that we've seen. And then for individual people, the actual understanding among residents and local government about CHIPS and the full scope of the services it's supposed to provide, including home visiting, is somewhat limited. And they think of it mainly as CHIPS compounds. And that also sort of limits the extent to which there can be advocacy for change. And that is the end. Thank you very much.
Fantastic. Thank you, Lauren. That was really interesting to see, and that real focus at the community health level services and the challenges and differences across genders and across different religions, and in those settings, how that influences people's access and perceptions of CHIPS. Thank you very much. So now if I can turn to Abriti, who is going to present the work from the HERD team in Nepal. Thanks, Abriti. Over to you.
Thank you, Helen. So namaste, everyone, and thank you for this opportunity. And today, on behalf of Nepal team, I will be talking about the perception and experiences of urban poor from Pokhara, Nepal, in regards to pathways to seeking care and how different social stratas has actually influenced the care-seeking pathways of the urban poor. So just to start with the context of Nepal, Nepal has a decentralized public health system with 3 tiers of government, which includes federal, provincial, and local, and they have and they each have their defined functions and authorities. And now, health is a shared responsibility of all three tiers, and with this, now the local authorities has the responsibility of delivering basic health services and other health programs, providing the opportunity to make the health services more inclusive by knowing the contextual needs of the population. So in terms of, so there is now increasing urbanization with the diversity in urban population, which has been receiving limited attention. So our study site, Pokhara Metropolitan City, is among the top 5 largest populous cities of Nepal, and with around 9,000 families living in slums and poor settlements, who are also the urban poor. And further marked by the urban population, urban poor faces unequal burden and additional hardships for livelihood and also access to basic health services. Further, the intersection of urban poor with other social stratifiers such as occupation, income, gender has further created multiple vulnerabilities, making it more difficult to access the basic health services for them. The Constitution and policies do have talked about addressing the health-seeking barriers for urban poor. However, mainstreaming such strategies and addressing the needs has been a real challenge in the current context. So in this study, we conducted social mapping, project work, and focus group discussions and interviews with community people and urban poor, key informant interviews with stakeholders at all 2 levels to further understand the influence of different social stratifiers such as age, gender, occupation, income of urban poor with care-seeking pathways for the healthcare services. And the analysis was done using thematic framework approach, which was also guided by the Morgan's et al. Gender framework. So now the findings are presented based on the domains of Morgan's framework. So you can see some of the pictures from the work that we have done, the social mapping, access mapping, and the FGD with the adult female. So moving on to the major findings, which is more guided by the gender domain of Morgan et al.'s framework. So in most cases, it was found that decision-making process, so starting with the decision-making process, the urban poor were found visiting different service providers, which included government health post, government hospitals, private clinics, pharmacies, traditional healers, among others. And in most cases, it was found that the decision-making process was participatory with the engagement of different family members. But then the decision-making in most cases, the final decision-making in most of the cases were made by the head of the household, who were particularly male members, whereas the other family members, including female, were supporting the decisions made and also helped them in the making necessary arrangements and accompanying the members to the health facility. So so you can see the quotes there from this study, which says like mainly husbands takes the decision, but in the absence of husband, female or the wife decides about the care-seeking pathway. So in some cases, it was also mentioned that FCSVs and others were also consulted for the health care-seeking pathways, or where this would be going for a particular illness, and for the type of illness was also found to have influencing the decision-making process and the type of health service providers. For instance, for a minor illness, they usually visit pharmacies or the nearby health facilities, and for the major illness, they tend to visit private hospitals and others. So moving on to the access to resources, economic status was found to also determine the choices for the type of health facility. So they preferred government health facility as the services were free of cost, affordable, and were also covered by the insurance services. So they had to make very less out-of-pocket expenditures. However, other opportunity costs, such as time, they need to separate to reach the health facility, and also the opening the hours of the health facility made them to choose facilities that are nearby. And in most of the cases, there were pharmacies and private health facilities. So in such situation, they chose they preferred paying for the care seeking rather than going to the health facility and waiting the entire day and losing the money they would be earning in a day, which is very important for their everyday livelihood. So you can see the second quote from the finding, which says like some people may have to reach to their work at around 10 a.m. and the government health facilities opens at 10 a.m. and they have to walk here, which consumes time. For taking one injection, sorry, this is a family planning device, injection. So it would take them a day, which means their 500 to 600 rupees is lost because they're unable to reach to their work on time. So similarly, elderly people also preferred nearby health facilities, which is connected with good transportation lines. And now moving on to the who does what, both men and women are mostly working as daily wages workers and are engaged in occupations such as sand mining, constructions, waste management, goods transportation, among others. So which has created health risks due to the working environment and made them more vulnerable, which was further coupled with the lack of nutritious food they are receiving. So because of the working environment, there is a level of stress among the urban poor, respective be it men or women, but mostly among men, which has forced them to intake alcohol and tobacco, risking creating the health risk. So there is a quote which says like, we started drinking alcohol to curb the physical and mental pressure of providing for the family. This caused hypertension and increased blood pressure. So similarly, based on the occupation, daily wages workers and small business owners, both men and women, they preferred nearer health facilities in most cases, which is other than government health facilities, to save their time determined by the opening hours, travel distance over the cost they need to pay for the services. So the quote says like—
2 minutes less, Debriti.
Okay. So moving on with the how are values defined, or the gender norms. So the gender norms was also found to have influencing the care-seeking patterns. So with the dual responsibility of both the men and women, dual responsibility of the women to perform both household and other livelihood determine the services choice, and irrespective of people's age and gender and education, socio-cultural belief on traditional healing also shape the care-seeking pathways. So in summary, so there was different care seeking, so different pathways were so in conclusion, like different types of health facilities were visited by the urban poor for the healthcare seeking, which was broadly determined by the system level factors such as availability of health services, cost of the health services, opening hours of the health services, and distance to health facilities. However, these broader factors were found to be intersecting with the other individual social categories such as type of illness, occupation, gender, economic status, cost, time, distance, among others, that actually shape the perceptions and experiences of urban poor for deciding the care seeking pathways. And we can see like there is a different, like the decision made for every type of health facility has a certain reason, which is further intersected by the gender, occupation and income. So yeah, so this is, so yes, I think thus the health system requires contextual adaptation based on the specific needs of urban poor. So in order to make the health services accessible and affordable to the marginalized population. So yes, this is all from my side, and I would like to thank everyone who were directly or indirectly engaged and supported this study. Thank you.
Thanks so much, Abriti. That was really a great overview and brilliant to see the depth of issues coming out and that clear analysis of the health system. And thank you very much for sharing that. So if we could move to the final presenter. Sushama Kanan from ARC Foundation. Sushama, if you're able to go ahead. Brilliant. Thank you.
Hello, and good morning. I'm Sushama Kanan. I'm presenting on behalf of ARC Foundation from Bangladesh. As you already have heard, that CHORUS is a bigger project. And in this project, Bangladesh is mainly focusing on strengthening urban primary healthcare system to deliver essential NCD care. And by the term essential NCD care, we are focusing mainly on diabetes and hypertension. So based on the needs assessment phase of this project, I'll be presenting the influence of gender inequity on the health-seeking behavior of the urban poor in Dhaka, Bangladesh. Just technical glitch, the next slide is not coming.
Okay,
If you click on the slide, then the bottom, yeah.
Talking about the background of this study, you can see that over the years, urban population of Bangladesh is growing fast. And until 2021, according to the latest consensus, Bangladesh has 166 million people. Among them, over 59 million people reside in urban cities, which we have received from World Bank 2018 report. So, which means in the graph that it has increased around 12-fold since 1971 when it got its independence. And talking about the non-communicable diseases, in terms of non-communicable diseases, the prevalence between the urban and rural context, it is seen that when we look at the NCD risk factor, the lack of physical activity, alcohol consumption, lack of adequate fruit and vegetable intake, increased number of intaking processed food, the comparison is much higher in urban area than rural area. And it is also reported in various literature that the NCD prevalence is on the rise among urban poor in Bangladesh. Looking at the urban primary healthcare system in rural and urban area, you can see in the slide that in rural area, there is a three-tier system that has the community clinic at the community level, then union sub-center, and then sub-district or upazila level center. So there is a referral system. However, when it comes to its counterpart, urban primary healthcare system, it is predominantly covered by NGO clinic, which are mainly run by different donor funds And in this case, these NGO clinics are run by Asian Development Bank funds. However, there are many other NGOs who are running some sort of healthcare services like BRAC, USAID, Smiling Sun franchises, Medistops, and there are many other NGOs who are currently providing urban primary health care. So when it comes to what the government is providing for urban primary health care, there are government dispensaries and few tertiary level healthcare centers and private centers which are not run by government. So these government dispensaries and the tertiary care level centers, they are really small in number in comparison to the size of the population that they needs to be served. So looking at the objectives, you will find these 7 objectives are for the overall projects, among which the red ones are looking at the gender and intersection. So the objectives of this particular sections are firstly to explore gender intersectionality differences in availing NCD services, to understand patient preference according to age, gender, disability, income, location, and others. And the last one is to assess patient experience of receiving NCT care services in urban primary health care center. So the method we have followed here, we have analyzed the Bangladesh demographic and health survey data as a secondary analysis. And we also went through different published government documents, donor reports, policy briefs, which were published between January 2000 to December 2020. With the secondary data analysis, we also have done in-depth interviews. So in terms of gender, we try to maintain 10 from each of the group, male, female, and third gender. And we also talked to health facility manager, doctor, paramedic, pharmacist, and lab technician from the urban primary healthcare center. So the findings I will talk about, and just as Helen mentioned previously, that we have used the Morgan framework to analyze our findings. So the entire Morgan framework is specific to what constitutes the power relation among the different social strata. So we have tried to put in our findings in accordance to each of the domain. As in who has what, we have found that most of the patients predominantly attending these centers are females, because the urban primary healthcare system is mainly focusing on maternal and child health, and they also provide sexual reproductive health, which is also focused on females mostly. And secondly, because the urban primary healthcare centers are more female and child oriented, the health workforce has also become predominantly females. When we actually went and conducted these interviews, these are the findings where the respondents mentioned that it was kind of deliberate choice, a purposeful choice, since the client group is predominantly female, so the healthcare worker would be chosen on the basis of their gender. The main reason behind this is the patient who attend such clinics who are female, they actually prefer female healthcare provider to talk to or to access their service from this center. And thirdly, there are an absolute inadequate number, and there is lack of male counselors for male patients at the urban primary healthcare center. Moving on to who does what, we have found that the urban primary healthcare center, they operate mainly from 9 a.m. to 4 p.m. on working days. So considering the context of the urban primary healthcare center and the surrounding urban slums from where the urban people actually come to take the services, the urban men in reality are not really available at those working hours. At most of these working hours, most of them being day laborers, these are the operating hours when they are not really able to attend these urban primary healthcare centers at all. as a result of which, when we went to the centers during the work hours, we actually see predominantly females rather than males, as you can see in that slide.
Sushama, you have 2 minutes left.
And the values, how it defined. So we found that there is a huge stigma across the healthcare providers and also the other clients regarding the third genders. And because the third genders face so much stigma and they're pretty much neglected, consequently, they hardly attend the other family healthcare centers. So I think it's good to inform you that we conducted most of the interviews in the community. So when we conducted this interview in the slum areas and we talked to the third genders, they express like how they face a lot of stigma and consequently how they would not be able to avail any NCD or any kind of healthcare services from the urban primary healthcare centers. And if you read the code in the slide where a third gender community member said that he went in urban primary healthcare center once, they requested healthcare services, but they were not listened to, and they directly tell them, the healthcare provider directly tell the third gender that there is no treatment for transgender like them, and told them to go away. And in addition to that, I already have mentioned that females are more attended by the healthcare providers since they visit the centers most often. And who decides? So what we found that in terms of who decide, the retention of the male healthcare worker is really very, very low, and there are multiple reasons behind that. One is there's a matter of salary structure. And in terms of salary, the salary structure was more important for males than in contrast to the females. And you can see in the code that one of the healthcare providers said, we cannot, one of the facility managers said, we cannot retain male health service provider much because our salary structure is poor, and with each term it decreases. So men are not interested to continue working. Moving on to the next slide, which is individual and people. So here we found out that the urban healthcare system mostly excludes males and other influential family members, and the centers are more focused on SRH and MCH services, which is predominantly women-oriented, but the males are often play a very important role when it comes to the health-seeking behavior amongst the females. And the last one is our structural and environmental. So there are some issues from this sector as well. So the urban primary healthcare structure is as such, it mainly caters to the needs of maternal, child, and sexual reproductive health. So, which makes the male patients for not thinking about taking healthcare service from these centers. And the third genders, they are absolutely neglected in all aspects of NCD management, of receiving and receiving from any kind of care. And while we did the secondary analysis, we also found that the third gender category was not included in the BDHS data till that time. And since it is not focused to NCD, so healthcare providers are not receiving NCD-related training in their centers. That is all from our needs assessment phase, and thank you from the team.
Fantastic. Thank you very much, Sushama. Really interesting to see all of those findings. And thank you to the whole panel for some brilliant presentations. And I think the issues emerging around the challenges of primary care access for particularly for men, for transgender, and this focus on maternal and child health rather than all the other issues that people are facing in terms of stigma and mental health, in terms of injuries and occupations. And I think some of these issues are really coming out across all the presentations. So thank you very much, presenters. So I'd like to turn to our attendees. We have a select group of attendees, and if any of you have any questions, please do shout them out. And we have one comment from Kate saying, thank you for citing our paper on gender in health systems. And what a great session it was. Thank you for that, Kate. And I know that particularly the framework, the Morgan et al. Framework, I think we've all just found it really useful as a way to structure both the data collection and the analysis to really tease out these issues. So yeah, it'd be great to hear anybody else has had kind of used similar frameworks or kind of used that in their research and helped as a way to really help tease out these gender issues. Any other questions from anyone? Or actually from other panelists, if you want to ask your other speakers any questions about their data, then please do go ahead. Maybe I'll just jump in as chair, because one thing I'm really interested in, a few of you were mentioning how the gender norms, you kind of hinted that gender norms seem to be changing as people are living in the city. And I wondered if across your data and really looking at and the experience of talking to men, women, transgender, whether you feel like there is this shift in gender norms as people move to the city and sort of start to sort of live quite a different life in the city, with women working outside the home long hours. A lot of you mentioned that in your presentations. So yeah, it'd be great to have some reflections, and maybe Chinyere, could I come to you first? Do you think that's something you're seeing from the participants that you spoke to, that gender norms are actually changing for them because of urbanization and their experience of living and working in cities?
So yes, so absolutely, yes. So from interviews, can you hear me? Yes. So from the discussions we had with these people, yes, absolutely. The gender norms are shifting. Women are taking on additional roles as providers in the household, in addition to the caregiving roles. I mean, so for the men, it's not apparent from our discussions that they are taking on, additional roles in caregiving. However, for the women, so they are taking on additional roles, as providers, as well as their caregivers in the home. So they have to go out and work and come back and still take care of their homes. And there's actually an instance where a married woman actually said she was the breadwinner. And the interviewer asked her severally, no, this is what we mean by breadwinner or head of household. She said, yes, I said I'm the breadwinner, So, and that is in addition to her responses about having to take her children to seek for care and all of that, having to care for her mother-in-law who lives with her and all of that. So yes, they are changing, maybe not for the better for women. Yes, but that's what we are finding. Thank you.
Thank you, Chinyere. That's really interesting. Any other reflections? Would anybody, Deepa, would you like to, sorry, Abriti, would you like to respond? Sorry, I'm looking at the list of attendees as well. Abriti, would you like to respond from the?
Yeah, I think in addition to what Chinyere just mentioned, I think if we look at the the roles is the household chores is still considered a primary responsibility of a woman, but then if you see the decision-making pattern, so it seems like the decision it's more participatory now. Yes, it's male make the final decisions, but then at least they are discussed with women or other members of the family and made the decisions. And particularly that could be the reason for because women these days work, they earn, and they are also one of the responsible person to make the livelihoods of their family, and they have a role in that. So probably that has a good linkage with the changing gender norms at the family level. Yeah.
Thanks, Abriti. We've got some really good questions coming up in the chat as well, which I think is like a common theme of how do we actually, what kind of advocacy do we need to do? How do we share these findings with policymakers to actually create change? And actually, I want to focus this one for Sushama, because Sushama is the lead for gender and intersectionality across Chorus. So Sushama, would you like to just give us some insights on how we can use these findings for advocacy and to change policy and practice?
Yeah, thank you, Helen. So in our cases, we have seen how third gender community are really neglected, and there is literally no healthcare services for them. So what we are thinking is conducting some, sensitization workshop meetings with the healthcare providers, because according to government, actually, the law permits them that the law is equal for everyone, and they are actually included for accessing the healthcare services. Just the problem is the mindset of people, not only the healthcare provider, but also the other clients who will be receiving services from the same healthcare center. So it might be one strategy, like the sensitization workshop campaign in the community. And I think gradually people are talking. Media can play a big role here, and I think we can also use them to highlight these findings regarding this inaccessibility, that the inequity between different genders.
Yeah,
So,
thanks, Sushama. I think those are really good points. I know that the session we've now reached 1 o'clock here in Valencia, so we do have to end the session. So I just want to say a massive thank you to all of our Chorus speakers, and thanks for the participants for your great questions. And yeah, thank you for joining. Okay.
Thank you so much, Helen. Thank you, everyone. I'm really excited to take this forward. So enjoy the conference.
thank you.
Thank you. Thank you.
See you.
Thank you, everyone.